Hey, what's up, lovely people? I hope you guys are doing pretty well. I'm doing fine for now. And I'm saying for now because the night literally just started because I got like so many things that I gotta do. But this week we're gonna mainly be talking about like uterine disorders and bleeding and stuff. And it's gonna be a little bit like why am I talking about this? And I'm gonna give you my reason right now. First thing first, I wanted to pass the test, which I did this morning. Second one was for my patient because I don't get to choose what the patients come with. But what I do is whatever the patients come with, I better know it well, learn from it, and then that's pretty much it. What my other reason is because I have two sisters, so these are the things that they go through every month. So it's like nice for me to actually know or have an idea of like what they actually go through every month, so I can you know be a little bit mindful about how I act and what I say and be a little bit more supportive. And my last reason is because I know I want to have kids some days, and I don't really think that people can choose gender. But like, bro, like I gotta know this, and these are my reason. So that's it. So that's what I'm gonna be talking about. And if you don't wanna like hear people talking about blood and stuff, you probably have to skip this and do something else, I guess. But hey, that's it. So let's begin. All right, so first thing first, this section is going to be mainly about the pathophysiology. You're going to be talking about cycle, what a cycle is, duration, and then some abnormal trend that needs to be looked into when it comes to cycles and stuff. So, cycle 21 to 40 days. So you're going to have the first day of one period to the first day of the next one. One of the misconception or the things that one of the things that I used to think before, which is really fucked up coming from me, is I used to think like, hey, you're gonna be bleeding like for 21 or maybe 40 days, which doesn't make any sense as I'm thinking about it now. Because if somebody is actively losing blood within this time frame every single month, it would have been dead at some point or something else. But it's just like now I'm understanding like there's a cycle, right? But there's a duration within the cycle when the bleeding actually does occur, which is from 2 to 8 days. Pretty important to not get the shit messed up. I really don't know how I got it messed up before, but it's just like that's what I used to think. And when it comes to the bleeding, right? So the bleeding, there's like different patterns that you need to be in the lookout for as well. But main thing when it comes to the bleeding though, so it's like you shouldn't be losing. Well, it's let's say there is a range. It's like from 40 cc to like 100 cc, but you shouldn't be like losing more than 100 cc because that'll be a problem, and you shouldn't have maybe like less than 40 cc. That also will be a problem. Will be something that they need to look into because you're gonna have abnormal patterns such as like metrorrhagia. So it's pretty much like gonna be like spot in between. So it's not gonna be linear. So you're gonna have like some small amount of blood right now, small amount of blood. You're gonna change your pad, and then blood, change your pad, but it's not gonna be like regular, or it's not gonna come as I'll say it should normally come, or as expected. And then you're gonna have menorrhagia, right? So which is pretty much like you're bleeding a lot, way much more than 100 cc, and then you have to change your pad more frequently because you are bleeding a lot and your pad are being saturated. And you're gonna have what else? What's that? Menorrhagia. But when it comes to this though, so there's like two main types. There's like the primary amenorrhagia, which is gonna be like the genetic related one. So 15 to 16, you still don't have your period, so it's can be genetic related. And then there's the other one when you used to have your period regularly, right? And then you spend like 2 months without having it. So which is also one type of amenorrhagia that also needs to be looked into. So yeah. All right, now we're gonna be talking about risk factors and stuff that you guys need to understand or just know, honestly. So these abnormal patterns are not diseases, but on the other hand, symptoms. And there is a need for me to make like a really big difference between what a disease is and what a symptom is. So you're gonna have a disease, right? So you're gonna come with a set of symptoms or clinical presentation to provider, and based on said symptoms, clinical presentations. So there is gonna be a diagnostic for the test might reveal that you have a disease. So this specific disease that you have might either be curable, they're gonna give you some medication or whatever it is they're gonna do so they can cure you from it, or something you cannot be cured from. where the care will be something they will manage for the long term, or something will be like palliative care or other type of care. But just to like give you the gist of like there's some stuff you can cure and there's some stuff you cannot cure, which I guess everybody knows sometimes at this point. Not sometimes, but all right, let's go back. So you also have symptoms, which are your body telling you that, hey, there is something you need to be in the lookout for. There is something you need to go and check. So when it comes to stuff like this, you need to go see a provider or someone who knows more than you, so they can find out whatever it is you got going on in your body. And the thing is, the easier they find out, the higher your prognosis are, which is like the chance of you getting better. So there's that, because some people sometimes, that's it, some people sometimes, so some people see it as, all right, so I'm having like spotting, I'm having like heavy bleeding, therefore I have this disease. They put in their mind, even if they don't put a name on it, but they will try like to find something from either a family member or something on the internet so they can cure themselves. But the underlying problem is not actually being looked into, and it's just like make more problem, because there's multiple things that can cause this abnormal bleeding, such as you will have hormonal imbalance, which is going to be estrogen and progesterone, which is going to be a thing I'm going to be talking about in a few. So it might either be a tumor too, which can be malignant, or other kind of tumor. This need to be looked into as well, so they can find out, hey, what stage it is, if it's a tumor, right, and stuff like this. Can also be what, um endometrial hyperplasia, which is also something I'm going to be talking about too. So it's like multiple things. Go get checked out and be safe, I guess. All right, so now we're going to be talking about endometrial hyperplasia, and when it comes to this, there is like two main hormone we're going to be talking about, or you need to keep in mind. It's going to be estrogen and progesterone, right? So endometrial hyperplasia. So you're going to have your uterus, or people will have uterus, right? So shouldn't be funny, but all right, people will have uterus. So what actually does happen? Too much estrogen, right? The lining of the uterus is gonna become thick. So you need progesterone to balance it out. And the thing is, you have too much estrogen, the lining of the uterus is gonna be thick or become thick, and you're gonna have low level of progesterone. The lining is gonna the line is gonna shed, and then bleeding spotty. So one thing you guys need to understand when it comes to like progesterone level and stuff like this is pregnancy. How does this thing actually does happen? Right. So you're gonna have your ovaries that will actually do the good stuff, release the egg. As soon as the egg is released, so now there's gonna be for the estrogen level will start rising. But fertilization need to occur for the cases and be the options to actually happen. So if fertilization does occur, right? So the embryo is gonna tell this specific membrane, I'll call CL, to just keep producing progesterone level, and so the lining can stay in place. The lining will be maturing, and then so the embryo can go and implement into the lining, and then you have your regular pregnancy. But if the fertilization is not happening, or something happened, fertilization failed, right? So everything will be destroyed within, well, it's not gonna say everything will be destroyed within one day, but I think the embryo will be destroyed within one day. Is that the embryo or the egg? It's gonna be destroyed within one day. I don't remember. My mind is trying out. And then the membrane is gonna wait a little bit to see what's up. And when the membrane see like, hey, there is no implementation, the membrane is gonna shed, and then you have your bleeding. So that's pretty much it. So that's why there needs to be a balance between your estrogen level and your progesterone level. And too much estrogen, you gotta keep that in mind. The membrane is gonna become thick. And when you have too much estrogen, and then you're gonna have less level of progesterone, the membrane will shed, and then you have sparking blitzing. That's it. All right, so now we're gonna be talking about medical diagnosis and what else? What did I put on this? And treatment. Your patient coming with uterine disorders or suspecting uterine disorders. A couple of things they're gonna be doing. It's probably gonna be ultrasound done so they can kind of see what they're dealing with. But the main thing is physical assessment. Gonna assist patients, gonna like know what's up, what you can see with your eyes, and then gonna take the history, family history of the patient's personal history of the patient's gonna like know to kind of like put the dots together and guide you into your next course of action. And other things will be treatment options. There's are multiple things they can do. For example, like contraceptive measures. They got like oral contraceptive measures with birth control or progestin, but they can also put an IUD, which I've learned was it's gonna be in place for 3 to 8 years. I didn't know that. And really small amount of hormone, and that's actually what block, I'll say, ovulation, and that's the reason why you're not pregnant, or your chance of getting pregnant with an IUD is lower. But yeah, what else? Surgery is one of the treatment option as well for people with like abnormal, well, no bleeding or maybe abnormal bleeding and stuff like that. What does that have on this? Oh, when you have your patients with uterine disease, there's like two labs you gotta keep in mind, or you gotta really keep looking at, will be your hemoglobin and hematocrit, because if there's that bleeding loss, you're gonna like know, like bleeding loss, fluid loss, fluid shifting to the left, electrolyte imbalances. Like these are things that you need to be like, oh my god, things that could happen, and you need to know when they are happening. That's the reason why I got to take really good attention to the lab and see if there are any trends that is concerning. But yeah, that's pretty much it. There's other things in there, but I don't want to say it because I feel like they're way too personal. So I'm just gonna skip this and call it a day.